Before we formally open this event, we would like to put down some reminders. This presentation is being recorded. During the duration of this webinar, kindly turn off your camera and keep your microphones on mute. For questions and clarifications, please type your concerns in the chat box. Our moderator will go through the questions during the open forum. Also, please remember to fill out the evaluation forms before leaving the webinar. A link will be provided in the chat box later. For this breakout session, let us learn about the recent guidelines regarding management of patients with heart failure. This will be discussed by Dr. Paul John Ablaza, a cardiologist and echocardiographer currently practicing in the University of Santo Tomas Hospital, Tondo General Hospital, and Medical City Satellite Clinic. This session will be moderated by Dr. Andrew Kua.
So, good morning. Thank you for attending our postgraduate course. This morning, we will be discussing the medical management of heart failure in the non-acute setting, what the internists can use. So these are my disclosure. I received honoraria for speakership and staff trainings from Survey Philippines and AstraZeneca Philippines. In the 2016 ESC guidelines for heart failure was defined as a clinical syndrome of typical symptoms such as fatigability and dyspnea, and signs such as increased JVP, peripheral edema, and pulmonary prattles that is brought about by reduced cardiac output and elevated intracardiac pressure. Globally, heart failure prevalence has increased, and it all has affected many Asian population in terms of incidence and prevalence. 1 in 5 individual adult patients have a lifetime risk of developing heart failure, and 9 out of 10 patients with heart failure who are in current heart failure standard of care remains to be symptomatic and are increased risk of hospitalization. Because of this, different international societies as well as local societies such as the European Society of Cardiology and the American Heart Association came up with different guidelines on the management of patients with heart failure. The ESC 2016 classification of heart failure included first, heart failure with reduced ejection fraction, wherein patient had typical signs and symptoms of heart failure with a decreased ejection fraction of less than 40%. Patients with mid-range ejection fraction are patients with signs and symptoms of heart failure, and ejection fraction between 40 to 49%, with additional criteria that includes elevated levels of natriuretic peptides and at least any evidence of structural heart disease or diastolic dysfunction. Patients with heart failure with preserved ejection fraction has signs and symptoms of heart failure, an ejection fraction of more than 50%, an elevated level of natriuretic peptide in the presence of either either structural heart disease or diastolic dysfunction. The American Heart Association, on the other hand, would prefer to stage their patients that include stage A, wherein these patients have risk factors for heart failure but do not have any structural heart disease or symptoms. Stage B are patients with structural heart disease but without any signs and symptoms of heart failure. Stage C patients have structural heart disease with prior or current heart failure symptoms. And stage D are patients with refractory heart failure, and these patients require specialized intervention. The diagnosis of heart failure will always include the use of good history and physical examination, and both international societies gave a class 1 indication on history and physical examination in the diagnosis of heart failure. This is the Framingham Criteria. Since medical school, we were taught that in order for us to diagnose heart failure, we need to fulfill 2 major criteria, or at least 1 major and 2 minor criteria. And major criteria would include acute pulmonary edema, cardiomegaly, neck vein distension, the presence of hepatojugular reflex, paroxysmal nocturnal dyspnea or topnia, RALS, or a third heart sound. Minor criteria includes ankle edema, dyspnea on exertion, hepatomegaly, nocturnal cough, pleural effusion, and tachycardia. In the 2016 ESC guidelines, they tried to expand the signs and symptoms that are typical and specific of heart failure, and they come up with this more typical symptoms and more specific signs of heart failure. In the same guidelines, they come up with what laboratory tests should be extracted or should be requested. That includes a full hemogram, electrolytes, urea nitrogen, creatinine, liver function tests, metabolic profile that includes lipids, glucose, HbA1c, thyroid-stimulating hormone, and ferritin. They also include 12-lead ECG as a class 1C indication for patients presenting with heart failure. A chest radiograph is also important in diagnosing this patient. So what are the roles of biomarkers and non-invasive imaging in heart failure? The natriuretic peptides are released by failing hearts and are used as an adjunct to diagnosis of heart failure. It serves to prognosticate and follow up our patient, and it can also be a sensitive marker to rule out the cardiac cause of dyspnea. Once you have an increased left atrial pressure, an increase in left ventricular and diastolic pressure, any pressure within the chambers that would cause distension of this chamber, your atrial natriuretic peptide or your brain natriuretic peptide is secreted. This will lead to natriuresis, diuresis, and vasodilation, and decreased activity of the renin-angiotensin-aldosterone system. Once this mechanism of action or once this reaction causes decrease in ventricular loading, the levels of atrial natriuretic peptide and brain natriuretic peptide will go down. And in heart failure, if there is repeated increase in ventricular and atrial pressure, the cycle repeats itself. In the American guidelines, based on staging, the use of natriuretic peptide can be utilized for diagnosis as well as prognosis and risk stratification of patient. For stage A patient, natriuretic peptide are not used for the diagnosis and prognosis of patient. For stage C and D patient, your brain natriuretic peptide or your NT-proBNP can be used to diagnose patients for heart failure and also to prognosticate and risk stratify your patient. For patients who present at the emergency room due to acute decompensation or acute symptoms of heart failure, your brain natriuretic peptide or your NT-proBNP can be used to diagnose your patient, and they can also be used to prognosticate them and monitor their improvement before you discharge your patient. Echocardiography, primarily your transthoracic echo, is still the preferred imaging modality because it's readily accessible, it's reproducible, and it's cheap. In most guidelines, they receive a class 1 indication in order for us to determine myocardial structure and function, to identify patients who will be suitable for evidence-based pharmacologic and device therapy, such as an intracardiac device or cardiac resynchronization therapy. They also used to determine valvular function, right ventricular function, as well as pulmonary arterial pressure, and also echocardiography is used to determine myocardial structure and function in patients who will be receiving or who have received potentially toxic chemicals to the myocardium. Both the ESC and the American Heart Association listed transthoracic echocardiography and chest X-ray as a class 1 indication in patients presenting with heart failure symptoms. In so doing, if we are going to combine clinical history and physical examination, as well as all diagnostic examination, the European Society of Cardiology came up with the heart failure diagnostic algorithm. If a patient is suspected to have heart failure, especially in the non-acute setting, you have to look for any signs and symptoms of heart failure. And once you have signs and symptoms of heart failure, even one is present, you request for natriuretic peptides. And once these natriuretic peptides are elevated, you can clinch the diagnosis of heart failure. However, in some centers, wherein echocardiography is available, you can directly request for an echocardiography once you have a patient with signs and symptoms of heart failure. If you are going to combine a positive an elevated level of natriuretic peptide and a positive echocardiography examination, then you clinch the diagnosis of heart failure. If both will not give you any positive result, heart failure is unlikely. So we now discuss the guideline-directed medical therapy in heart failure. The goals of management of our patient with heart failure would always include patient education, improvement of their clinical status, improvement of their functional capacity and quality of life, as well as prevention of rehospitalization and reduced mortality. For patients who have stage D heart failure, it is always important to discuss end-of-life goals. This is the rationale for heart failure pharmacotherapy. And once your patient had myocardial injury, there will be reduction in the cardiac output. The reduced cardiac output would lead to decreased carotid baroreceptor stimulation and reduced renal perfusion, which in turn will activate the sympathetic nervous system and activate the renin-aldosterone-angiotensin-aldosterone system. The activation of your sympathetic nervous system would lead to increase in heart rate and increase inotropy. Although at start it will help to increase cardiac output in the failing heart, but long term it will cause myocardial toxicity as well as increased oxygen demand. On the other hand, the activation of your renin-angiotensin-aldosterone system will lead to vasoconstriction as mediated by your angiotensin 2, leading to increased afterload, and hemodynamic alteration as mediated by your aldosterone, increasing the preload. Your beta blockers will inhibit the activation of your sympathetic nervous system. Your ACE inhibitors and your aldosterone receptor blockers and your mineralocorticoid receptor aldosterone antagonists will act on the other side of the spectrum, as well as your neprilysin inhibitor. Different RCTs have looked at the benefit of different agents in heart failure. And if you are going to combine or do a meta-analysis of all these RCTs, they have found out 3 agents who have consistently reduced both mortality and morbidity in patients with heart failure. And these, of course, include first your ACE inhibitor, followed by your beta blockers. Next are your aldosterone receptor antagonists or your mineralocorticoid receptor antagonists. In patients who are intolerant to ACE inhibitors, you might want to use or you might shift them to an aldosterone receptor blocker. In the recent years, with sacubitril valsartan being introduced in the market, this is a study done by PARDEP, published in the British Medical Journal of Medicine or Cardiology, that have shown that your sacubitril valsartan with your ACE inhibitor or ARB, beta blocker, your mineralocorticoid receptor antagonist improves mortality and morbidity in patients with heart failure. In so doing, they have come up with this treatment algorithm in the European Society of Cardiology. First, once your patient who is suspected to be heart failure with a reduced ejection fraction is confirmed, the initial therapy should include an ACE inhibitor and a beta blocker. It is very important, and they have emphasized that you should start your patient low and up titrate to a maximum tolerated evidence dose or evidence-based dose. If the patient remains to be symptomatic, if they have already been receiving evidence-based doses of your ACE inhibitor and beta blocker, you can add a mineralocorticoid receptor antagonist that is started low and gradually up titrated to maximum tolerated dose. If the patient remains to be symptomatic, even if you have already an ACE inhibitor, a beta blocker, or the mineralocorticoid receptor, you have 3 options. If the patient is able to tolerate an ACE inhibitor, you can shift this patient to an neprilysin inhibitor such as sacubitril combined with valsartan. If the patient is in sinus rhythm with a QRS duration of more than 130 milliseconds, you might want to refer this patient to an electrophysiologist and discuss the probability of using cardiac resynchronization therapy. In patients who have maximum beta blockers and yet they have a heart rate of more than 70 beats per minute and in sinus rhythm, you might want to include ivabradine in managing your patient. If this patient remains to be symptomatic despite the use of neprilysin inhibitors, your ivabradine or the use of cardiac resynchronization therapy, when they have resistant symptom, you might want to consider left ventricular assisted device, heart failure transplantation. But again, these are topics or these are management that should be made into consideration with a cardiologist. On the other hand, the American Heart Association tried to manage this patient based on stage. For patients with stage A heart failure, it is recommended that you give or you advocate healthy lifestyle, prevent vascular or coronary disease, and prevent left ventricular structural abnormalities. And again, the agents to be used should include an ACE inhibitor, an ARB, or a beta blocker, or a statin as appropriate. For patients with stage A, the goal of management is to reduce risk factors or improve risk factors in this patient. Patients on stage D, on the other hand, these patients are who had previous MI, who have left ventricular remodeling, who remains to be asymptomatic. The goals is always to prevent heart failure, prevent further cardiac remodeling, and the agents would always include an ACE inhibitor, an ARB, and a beta blocker. For patients with stage C and D heart failure, the American Heart Association came up with a different algorithm. First is to determine or establish the diagnosis of heart failure with reduced ejection fraction, assess the volume, and initiate guideline-directed medical therapy. And this includes your ACE inhibitors, your ARBs, and beta blockers. Diuretics can be used as needed. Once you started your patient on these agents, you have to reassess them again, and you have to look for clinical signs and symptoms that will help you if you have to up-titrate your agents or you have to add another agent. In patients with NYHA class 2 and 4, provided that their creatinine clearance is more than 30 ml per minute and their potassium is less than 5, you can add aldosterone. In patients who have NYHA class 2 and 3 heart failure with adequate BP control, you might on ACE inhibitor or ARB and no contraindication for an ARB or sacubitril, they can shift your patient to sacubitril valsartan. In black patient, you can add a hydralazine and nitrates. And your ICDs in your CRTs should always be discussed with a cardiologist. Once you started these second-line agents, you have to reassess your patient again. And once they are refractory and they would have symptoms despite maximum levels of these agents, consideration would include palliative care, transplant, and LVAD, and should always be discussed with a cardiologist. This lists the different guideline-directed medical therapies, the starting dose, as well as the target dose for these agents. They have given us all doses for ACE inhibitor, for beta blockers, ARBs, mineralocorticoid receptor antagonists, your sacubitril, and your ivabradine, both from the ESC and the American Heart Association. Let us now discuss comorbidities in heart failure. And the two most important comorbidities in heart failure includes hypertension and diabetes. In the American Heart Association, hypertension is managed, and the target blood pressure for patients with increased risk of heart failure or stage A heart failure is a systolic blood pressure of less than 130 and a diastolic blood pressure of less than 80. For patients with heart failure with reduced ejection fraction, the systolic blood pressure is targeted at less than 130 millimeters mercury. In patients with preserved ejection fraction and with persistent hypertension, the target systolic blood pressure is less than 130 millimeters mercury. This is the latest 2020 International Society of Hypertension core drug treatment strategy in patients with hypertension. They always emphasize the use of single pill combination therapy in our patients. And step one would always include low dose combination therapy of a renin angiotensin aldosterone system blocking agent, a calcium channel blocker, or a diuretic. Step two is wherein your patient who are in low dose dual combination therapy or single pill combination therapy and they remain to be hypertensive or out of target, you do full dose of this single pill combination therapy. If your patient remains to be hypertensive despite dual full dose combination, you can do triple combination that includes a RAS blocker, a calcium channel blocker, or a thiazide-like diuretic. If this patient remains to be hypertensive despite triple therapy, you might want to work up your patient on resistant hypertension and start your patient on a mineralocorticoid receptor antagonist. Although this guideline did not focus on patients with heart failure, but instead focus only in patients with hypertension, what is of note is that the agents that is being used in both patients without heart failure and with heart failure always includes a RAAS blocker, a diuretic, an MRA, and a beta blocker. In the European Society of Cardiology, in patients who are in heart failure, NYHA class 2 to 4 and are hypertensive, class 1 agent would always include an ACE inhibitor. And if they are intolerant of the ACE-associated cough, you can shift them to an ARB. Other class 1 agent also includes a beta blocker or an MRA, which are also in parallel with the agents that is needed in heart failure. How about diabetes? In most guidelines, in patients with diabetes and heart failure, the recommended dose would always be near normal or an HbA1c of less than 7%. In the latest guidelines of the American Diabetes Association in 2020, the first agent in the management of diabetes would always include metformin and comprehensive lifestyle modification that includes weight management and increase in physical activity. Once your patient presents with heart failure symptoms, particularly in patients with reduced ejection fraction that is less than 45%, and a decrease in renal function, or they have already CKD, the preferred agent is an SGLT2 inhibitor with evidence of reducing heart failure and CKD progression. If these patients are intolerant of an SGLT2 inhibitor, you might want to start a GLP-1 receptor antagonist. In summary, the pharmacologic management of patients with stable heart failure includes proper diagnosis that is based on history and physical examination. The biomarkers are used to diagnose and prognosticate patients, especially if they are in stage B, C, and D. And transthoracic echocardiography remains to be the imaging of choice because of its accessibility and reproducibility. The agents that are used in patients with heart failure should always be tailored in each individual patient, and the agents always be used are ACE inhibitors, beta blockers, and your mineralocorticoid receptor antagonists. And if these patients are intolerant to ACE inhibitors, you might shift them to an aldosterone receptor blockers or ARBs. The target systolic blood pressure in patients with heart failure is less than 130 millimeters mercury, and the target HbA1c is less than 7, that is balanced with compelling indication in each individual patient. Thank you.
For the next lecture, we shall learn about the latest advances in the treatment of hypertension with Dr. Lauren Valera. She graduated cum laude from the University of Santo Tomas Faculty of Medicine and Surgery and was the chief fellow during her fellowship training. She is currently the head of the Intensive and Critical Care Medicine of Metro Lemery Medical Center. This session will be moderated by Dr. Andrew Kua.
Good morning. Today, I will be talking about the updates on the hypertension guidelines by the International Society of Hypertension, which was published last June 2020. We all know that hypertension is the leading cause of death globally, accounting for 10.4 million deaths per year. Blood pressure trends show a shift of the highest blood pressure from high-income to low-income regions. There is an estimated 349 million hypertensives in high-income regions and 1.04 billion in low-income regions. This large disparity between regions is brought about by low levels of awareness, treatment, and control rates in low-income regions. Awareness is 67% in high-income region, while it is a mere 38% in low-income region. Low and middle-income regions often follow guidelines of high-income regions closely. This adoption of guidelines from high-income regions are sometimes impractical as low-resource settings are confronted with limited ability to conduct the recommended diagnostic procedures. Because of this, the ISH came up with worldwide practice guideline for the management of hypertension. They focused on practical issues related to the management of hypertension in high-income and low-income region where there is limited access to resources. Standard of care is classified as essential or optimal. Essential care refers to minimum standards of care, while optimal care refers to evidence-based standards as stated in the guidelines. So what is now the new normal in hypertension? According to the ISH, hypertension is diagnosed when the systolic blood pressure in the clinic is more than or equal to 140 mm mercury and or the diastolic blood pressure is more than or equal to 90 mm mercury following repeated examination. At-home blood pressure of more than or equal to 135/85 mm mercury, 24-hour ambulatory blood pressure of more than or equal to 130/80 mm mercury. This table shows us the similarities and differences in the definition of hypertension across the three major hypertension guidelines. Again, this is the definition of hypertension in the 2020 ISH guidelines. Office blood pressure of more than or equal to 140/90 mm mercury. Comparing it with the 2018 ESC guidelines, we can see that they have identical definitions of hypertension regardless of whether blood pressure is measured in the office, at home, or using the ambulatory blood pressure monitor. The ESC guidelines defined hypertension as the level of blood pressure at which the benefits of treatment, whether lifestyle interventions or medication, outweighed the risks. In contrast, the 2017 AHA guidelines used lower values to define hypertension in the office, at home, or using the 24-hour ABPM. Hypertension is when the BP at the clinic or at home is more than or equal to 130 over 80 mm mercury, or when the 24-hour ABPM is more than or equal to 125 over 75 mm mercury. The lower definition of high blood pressure serves to account for complications that can occur at lower numbers and allow for earlier intervention. The ISH also defined isolated systolic hypertension as systolic blood pressure of more than or equal to 140 mm mercury and less than 90 mm diastolic blood pressure. This is common in young and elderly individuals. In young individuals, including children, adolescents, and young adults, isolated systolic hypertension is the most common form of essential hypertension. This table shows the blood pressure categories of the three major guidelines. According to the ISH, normal blood pressure is systolic blood pressure less than 130 mm mercury and diastolic blood pressure of less than 85 mm mercury. High normal blood pressure is systolic blood pressure 130 to 139 mm mercury and or diastolic blood pressure of 85 to 89 mm mercury. High normal blood pressure classification is intended to identify individuals who could benefit from lifestyle intervention and who would receive pharmacological treatment if compelling indications are present. Grade 1 hypertension is defined as systolic blood pressure of 140 to 159 mm mercury and or diastolic blood pressure of 90 to 99 mm mercury. Grade 2 hypertension is systolic blood pressure of more than or equal to 160 mm mercury and or diastolic blood pressure of more than or equal to 100 mm mercury. Compared with the ESC, the 2020 ISH eliminated the optimal category, therefore defining normal BP as less than 130 over 85. They also eliminated the elevated and grade 3 category. We can see here the discrepancy between the 2020 ISH and the 2017 AHA guidelines, which define normal blood pressure as systolic blood pressure less than 120 mm mercury and diastolic blood pressure of less than 80 mm mercury. Elevated BP is systolic blood pressure 120 to 129 mm mercury and diastolic blood pressure of less than 80 mm mercury. Stage 1 hypertension is systolic blood pressure 130 to 139 mm mercury or diastolic blood pressure 80 to 89 mm mercury, while stage 2 hypertension is systolic blood pressure of more than or equal to 140 mm mercury or diastolic blood pressure of more than or equal to 90 mm mercury. Again, let's review. According to the ISH, the new normal blood pressure is systolic blood pressure less than 130 mm mercury and diastolic blood pressure less than 85 mm mercury. Grade 1 hypertension is systolic blood pressure 140 to 159 mm mercury and or diastolic blood pressure 90 to 99 mm mercury. Grade 2 hypertension is systolic blood pressure more than or equal to 160 mm mercury and or diastolic blood pressure more than or equal to 100 mm mercury. For the diagnosis of hypertension, all guidelines share the recommendation that hypertension should be diagnosed at more than 2 clinical visits at 1 to 4 week intervals. The ISH and ESC added that one single visit is enough for making the diagnosis of hypertension if the blood pressure is more than or equal to 180 over 110 mm mercury and there is evidence of cardiovascular disease. The ISH recognizes that optimal care would not always be possible as in the case of low-income regions. For diagnostic workup, essential standard of care would be, of course, complete medical and family history and thorough physical examination. The guidelines also advocates to screen all patients for substances that may increase blood pressure or interfere with the blood pressure lowering effect of antihypertensive medications. Essential lab tests include serum sodium potassium, serum creatinine, estimated GFR, urine dipstick test, lipid profile, fasting blood sugar, and 12-lead ECG. Under your optimal care would be additional diagnostic tests to assess and confirm suspicion of hypertension-mediated organ damage, coexistent disease, or secondary hypertension. These include your 2D echocardiogram, carotid ultrasound, ankle brachial index, renal or adrenal imaging, fundoscopy, brain CT or MRI, and other tests for secondary hypertension. This figure shows the recommended pharmacological treatment strategy. Lifestyle modification is still the first line of antihypertensive treatment. They also enhance the effects of antihypertensive therapy. Lifestyle modification include salt reduction with optimal goal of less than 1,500 mg per day. Avoid or limit consumption of high salt foods such as soy sauce, fast food, and processed food. Patients should be advised to eat foods rich in fruits, vegetables, whole grains, and polyunsaturated fatty acids. Moderate consumption of coffee, green, and black tea is also beneficial. Moderation of alcohol consumption is defined as daily limit of 2 standard drinks for men and 1.5 standard drinks for women. Patients should avoid binge drinking. Regular physical activity defined as moderate intensity aerobic exercise such as walking, jogging, cycling, yoga, or swimming for 30 minutes on 5 to 7 days per week. Patients should also avoid stress and exposure to air pollution and cold temperature. Pollution has a negative effect on blood pressure in the long run, while cold temperature activates the sympathetic nervous system. Thus, secretion of catecholamine is increased. This could result in an increase in blood pressure through increased heart rate and peripheral vascular resistance. We will now go to the pharmacological treatment of grade 1 hypertension. For grade 1 hypertension, essential and optimal care would be to initiate drug treatment in high-risk patients or those with cardiovascular disease, chronic kidney disease, diabetes mellitus, or hypertension-mediated organ damage. If there is limited drug availability, those at lower risk advise lifestyle intervention for 3 to 6 months, but start treatment preferentially in patients age 50 to 80 years old. If drug availability is not an issue, drug treatment in low to moderate risk patients without cardiovascular disease, chronic kidney disease, diabetes mellitus, or hypertension-mediated organ damage after 3 to 6 months of lifestyle intervention if BP is still not controlled. For grade 2 hypertension, the recommendation is immediate drug treatment in all patients. For the blood pressure target, the recommendation is target blood pressure reduction by at least 20 over 10 millimeter mercury, ideally less than 140 over 90 millimeter mercury. Reduction of blood pressure by 20 over 10 millimeter mercury is associated with 20% difference in cardiovascular risk. For patients less than 65 years old, the target blood pressure is less than 130 over 80 millimeter mercury if tolerated, but it should be more than 120 over 70 millimeter mercury. For more than or equal to 65 years old, the blood pressure target is less than 140 over 90 millimeter mercury if tolerated, but you should consider individualized BP target in the context of frailty, independence, and tolerability of treatment. Aim for BP control within 3 months. Let us now compare the three guidelines in terms of office blood pressure requiring therapy and blood pressure targets. The blood pressure requiring therapy and blood pressure targets of ISH and ESC guidelines are largely comparable. The AHA guidelines set lower values. The ISH and ESC recommend to start drug treatment immediately in patients with blood pressure of more than or equal to 160 over 100, regardless of other considerations, and in patients with blood pressure more than or equal to 140 to 159 over 90 to 99 millimeter mercury with overt cardiovascular disease, chronic kidney disease, and diabetes mellitus. Both guidelines state that those whose blood pressure is persistently in the range of 130 to 139 over 80 to 89 millimeter mercury without overt cardiovascular disease, drug treatment should be initiated after 3 to 6 months of lifestyle modification. In the AHA guidelines, drug treatment is recommended in all patients with office blood pressure of more than or equal to 140 over 90 millimeter mercury. When blood pressure is 130 to 139 over 80 to 89 millimeter mercury, drug treatment is recommended in patients with overt cardiovascular disease and in patients whose 10-year risk is more than 10% as part of primary prevention. Overall, the ISH and ESC recommend a general blood pressure target of less than 140 over 90 and individualized targets based on age, tolerability, and comorbidities. The AHA recommends an identical target of less than 130 over 80 in all subjects regardless of age and comorbidities. For patients with overt cardiovascular disease, chronic kidney disease, and diabetes mellitus, all three guidelines agree that the blood pressure target should be less than 130 over 80 millimeter mercury. A safety boundary of 120 over 70 millimeter mercury in the management of patients less than 65 years old is recommended in both ISH and ESC guidelines. The ESC based their recommendation on post hoc analysis of on-target trial, which showed an excess risk in all-cause mortality and cardiovascular mortality in association of achieved BP less than 120 millimeter mercury. The recommendations by the ESC and ISH on safety boundaries is in contrast with result of three major meta-analyses where they found that greater reduction in systolic blood pressure was linked with greater reduction in cardiovascular outcome events without any evidence of a J-curve effect. Overall, a systolic blood pressure target of less than 130 millimeter mercury offers a reasonable balance between safety and efficacy. For core drug treatment strategy, ISH recommends essential standard of care as follows. Use whatever drugs are available with as many of the ideal characteristics as possible. Ideal characteristics of the drug include evidence-based in relation to morbidity, mortality prevention, once a day daily dosing regimen, affordable and cost-effective, well tolerated with evidence of benefit to population applied. You can use free combination if single pill combinations are not available or unaffordable. Thiazide diuretics may be used if thiazide-like diuretics are not available. If dihydropyridine calcium channel blockers are not available or not tolerated, you may use non-dihydropyridine calcium channel blockers, diltiazem or verapamil. For optimal standard of care, ideally, single pill combination therapy should be used. As first step, dual low-dose combination of ACE inhibitor or ARB plus calcium channel blocker is recommended. If blood pressure is still not at target, you can increase the dose of your single pill combination therapy. If still the blood pressure is not at target, you can do triple combination of ACE inhibitor or ARB plus calcium channel blocker plus diuretic. In cases of resistant hypertension, you can use the triple combination plus spironolactone. The ISH recommends giving monotherapy in low-risk grade 1 hypertension or in the very old or frailer patients. Consider giving ACE inhibitor or angiotensin receptor blockers plus diuretic in post-stroke, very elderly, those in heart failure, or with calcium channel blocker intolerance. ACE inhibitors or ARBs plus calcium channel blockers or calcium channel blockers plus diuretics are considered in Black patients. Let us now look into the comparison of the three guidelines in terms of initial drug treatment. Both the ISH and ESC recommend monotherapy in low-risk patients and the very old. In all other cases, they also recommend an initial free or fixed drug combination. AHA recommends a free or fixed drug combination between two agents of different classes or more if needed. In stage 1 hypertension, AHA recommends initial monotherapy. ISH, on the other hand, recommends starting drug combinations at low doses to be eventually increased at full doses in case the blood pressure is still above target. ISH acknowledges ethnic-specific characteristics for East and South Asian populations. East and South Asian patients have higher prevalence of stroke and non-ischemic heart failure. Morning hypertension and nighttime hypertension are more common. Standard treatment in guidelines is advised for Southeast Asia. In summary, the highlights of the 2020 ISH guidelines are as follows. Blood pressure of more than or equal to 140 over 90 mm mercury requires drug therapy, including those aged more than or equal to 80 years old. Office blood pressure within 140 to 159 over 90 to 99 mm mercury and without overt cardiovascular disease, chronic kidney disease, or diabetes mellitus, initiate drug treatment in case of drug availability, preferentially in 50 to 80 years old. Essential BP reduction by at least 20 over 10 mm mercury. For more than or equal to 65 years old, blood pressure target of less than 140 over 90 mm mercury is recommended, plus consider individualized blood pressure targets. After examining the similarities and differences of the three major guidelines, we can say that the ISH guidelines are closer to the ESC guidelines with emphasis on key messages relevant to clinical practice in different parts of the world. That is all for today. Thank you.
You may now proceed to our industry-sponsored symposia. Please go to www.tiktok2021.com and click on the room you would like to join.